somewhere. Dr. First is unable to attend. Chris Briggs has to babysit.
Chris Uhas is here.
Chris Uhas, I know, is here. And young Dr. Wozniak, as usual, is making an entrance. Where's your cape? All right, so I think we have a critical mass. The minutes, I think, are on the website. Hopefully you've had a chance to look at them and yeah, Dr. Nixon moves approval. All approved. Yeah.
We cannot hear you. We can't hear you.
You want them hot?
Oh, you have to turn it on. My Aggie counterpart here, I figured that out. So this is too esoteric for TSIPs. So on the first on the agenda is, I had put in discussing the development of the database. We in Houston we have been working with now the CCTS or TCTS or something like that, which is the basically a NIH funded clinical trials group at UT. We've transitioned from the School of Public Health and actually have made a tremendous amount of progress. We had hoped to have something to show this time, but for sure we'll have something next time. And we also appear to have funding for that, which I'll share with you next time as well. In the meantime, I think Lonnie has 4 or 5 presentations to do. She's getting them loaded. Including the RAC survey. Have you got that information?
We have a guest.
So that'll... Someone will be presenting that. Are you ready? Yeah? Let's go ahead.
Is it on? Just a couple updates. They're all on the same slide set, so I'll just move from one thing to the next. But wanted to update about the Duke Mission Lifeline STEMI Accelerator project that's going on. The funding for it came from some national sponsors, their educational grants. And we have 2 areas that have been selected. San Antonio is going to be part of the project, and Houston is going to be part of the project as well. And you can see the other sites that were selected up on the screen. So the premise, it's really a research study that these regions will be involved with. The premise is that really hit STEMI systems of care hard, bring in some national faculty and using local leadership as well, look at the gaps of the system that still exist, if there are any, and move to really work intensively on those things to try to, the overarching goal is to decrease mortality rates from STEMI even further. So the funding covers an educational event day. So we'll be doing one of those next week in San Antonio, and we'll be doing the one in Houston the following week. They're day-long events. We've got guest speakers coming in from those, and then as local speakers as well, who are going to be going into STEMI case studies. Those are going on all throughout the country and in the 20 sites that were selected. There'll be faculty follow-up visits to look at the data end of this year or early January, depending on when those reports are finalized. And we're asking everyone involved to use a centralized STEMI database. So we're asking all hospitals in all of these regions to get on board with the National AMI Registry, Action Registry, if they're not already. Many of them are already, but we have some who aren't, but who will be joining, completely voluntary, but most of them are interested in participating. The first data set will be pulled between July and September, so the patients that are being discharged now will be included in that first data poll. And then we'll track that data through regional reports that are going to be compiled through NCDR, Forest Action Registry. And the final data poll will happen the fall of next year. And then in the spring, we hope to be able to compile that information, aggregate data only, and publish the results. We ask that each of the sites meet quarterly. The ones in Texas are doing that already, so that's not going to be a challenge for them. Doesn't change referral lines. It's just meant to augment the existing system. And regional system, when we talk about STEMI systems of care, we're talking about it can be defined in a lot of ways. We've got individual hospitals that are working really hard to improve their quality and STEMI system work. And then we also have the hub and spoke model hospitals that are working with their transfer hospitals to make that transfer seamless for the STEMI patients, the partnerships with EMS. What we're talking about here, these regional systems of care are plenary systems, all of the hospitals, all of the PCI hospitals, non-PCI hospitals, and really what we're doing, what we recommended through the RACs, all EMS agencies. So, what we find has been successful in all of our areas that have had some data and some results as leadership, funding, neutral coordination, data, feedback, and a single common plan. So the data is going to be a big focus of the project. We're asking everyone to sign a consent form to participate in the project. Also have to sign a Mission Lifeline consent form, and this is what the reports will look like. I will say that these selected sites are not the only ones eligible for this. The Austin region is moving to do this as well, and I know several others are looking at doing this also. So the only difference will be that they just won't sign the consent form for the accelerator project. This is just one page of the sample report. Some of you have seen this before. This just shows you how this is a de-identified report. Regions can choose blinded or unblinded data. This allows hospitals to benchmark to the other hospitals in the region. This one shows an example of one of the report pages that will allow the region to benchmark to other systems in the nation, around the nation. Another report that drills down a little bit further about what's going on in the system compared to the state and the rest of the nation. And I talked about objectives. Really, that middle one is what the main focus will be, and that's addressing mortality rates. This is a resource that has recently become available for the regions that are participating in the project, but also the resource manuals available to all of us. So I think we're going to talk a little bit later about sharing resources, and I can load this into the file that we're talking about creating, or the link that we're talking about creating. Really what it is an updated Race North Carolina STEMI Systems of Care manual. They've had an operations manual that's been out there and a resource tool for many of us for a long time. They've updated it with the latest science and are making it available to everyone. And then this is another item on the agenda. Dr. Smalling asked Chris and I and several others to kind of give an update on STEMI systems coverage in Texas. Chris and I talked earlier today and felt that this is probably the best thing to put up there, although it's not ideal. We still have a lot of areas in Texas that are not showing up as having STEMI systems coverage, and since this is self-reported data, we don't know how accurate this is. If you have a STEMI system of care, register your system, and for those of you who have been trying to register your system and it got stopped in the middle of the process, we're trying to send links out to those areas one by one. That's happening throughout the nation so that you can finish your questionnaire and get listed on the site. It does take a long time. Once you go in and fill out the questionnaire, it takes months to show up as a blue section on the map. But I'd love to have all of our STEMI systems that are active in Texas are RACs that have this STEMI work going on, register so so they show up as having coverage. The way to do that is just go on the Mission Lifeline website, go in and fill out a questionnaire.
Did you say,
45 minutes.
hey Lonnie, did you say RACs actually register or STEMI and referring
Both.
hospitals
Yeah,
register?
good question, thank you. So many individual hospital systems that have STEMI systems of care, so anyone who's really partnering with EMS or the non-PCI hospitals in their region can go on and register. I've had EMS agencies who go on and register for the partnerships that they have developed in their area. So you could be listed several times in there. You could be listed, so I'll give you the example of Houston. Dr. Smalling's facility, Memorial Hermann, is listed as a STEMI system of care. They've had partnerships with transfer centers and EMS for a long time. So they're listed in that way, but they're also listed as in the GETAC STEMI system of care. So we have all of the folks who've been coming together through GETAC and the Cardiac Care Committee and working on the STEMI processes registered on there as well. So you see a big block over the Houston area. So, I know Hot Rack is working to get theirs registered. Border Rack, Cat Rack is registered, and several others. We went ahead and registered Dallas County as the Caruth system. Website, americanheart.org/missionlifeline. And Dr. Smalling also had the thought that we really, we're all working, many of us have the same challenges, and different people have come up with different solutions in their areas to address their STEMI system problems, and for us to be able to share our challenges, share the solutions, bring our challenges to this group and ask how other people have come up with solutions to the problems is a really good thing. So sharing of information and best practices. And we've had a lot of really great presentations over the last year or so. We've had multiple systems talk about what they're doing. Next on the agenda is Hot Rack. So Chris Reeves and Rita and that group will be talking about what they're doing. They're really doing some cool and novel things in that area, and they've been working together really well for a long time. So anybody's interested in doing that for your region, please let us know. Last thing, I just want everybody to be aware of.
So Lonnie, let who know?
It'd probably be best. Do you
Not
want,
me, no.
The chairman.
So you can let Chris, you, Haas, or myself know.
Lonnie, is this on?
I don't.
Yeah, I think so.
Lonnie's plate is really, really full. I will be happy for you guys to let me know if you are interested in presenting at one of our committee meetings for your RAC or your region or your system. It can be a smaller type system. It doesn't have to be a whole system, but if you have something you would like to share with us, let me know and I'll filter it through Lonnie. And we would love to have you present what your system is doing out there.
The goal we sort of thought about was to give examples from varying different geographical population, et cetera, areas. So what works for one big area may not work for a smaller area, or what may work on the coast may not work in El Paso, for instance. So the idea was to share different types of systems and see how they're doing as what they're doing. So that's sort of the idea.
Thank you, Chris. So just two more slides. I wanted you to be aware that a lot of the parts of the country have gone ahead and adopted the new timeline guidelines. We've been waiting for the updated STEMI guidelines to come out. We're hoping that we have those by the end of the year, but still waiting. So the PCI guidelines that came out recently is what people are using to go ahead and update their timeline goals. So just so that everyone's aware, the first medical contact, so EMS eye to eye with that patient to device guideline goal is 90 minutes. That hasn't changed. The 120 goal is if the patient is starting in an outlying facility, the clock starts at that door, and the clock stops when the device is deployed or the vessel is reperfused, and the goal for that is 120 minutes, and that's a new thing, but you'll be seeing that, and I wanted you to be aware.
So do you have any insight about the guidelines?
None.
I cornered Alice Jacobs at the ACC, and she broke out into a sweat. But she didn't say anything. So she said she'd have to kill my firstborn, as she told me. So it's interesting, interesting. Anything else, Lonnie? Any questions for Lonnie? Okay. One of the other things that came up was trying to figure out what the RACs had been doing, and there was a RAC survey distributed, and Lonnie and her legions had the charge to contact the DSHS to see if we could get an insight into that report, and the contact that we originally were told would do it apparently is no longer with them.
Correct.
And so you have someone else.
So Kitten Hollowell, wonderful, wonderful.
Would you tempt us with your results from the surveys? Debbie?
Tempt is a key word there, sir. And yes, sir, I will. No. Let me distribute this real quick. And I'll provide a little bit of information around a little bit of background for this, but let me give each of you one of these. And if you'll just check out page 1, that's really where it is. Here you are. Thank you. And for you. Just a couple of introductory remarks. First of all, my name is Kitten Holloway, and I am serving as the interim lead for the Health Promotion and Chronic Disease section. As you may know, Dr. Kalanchi's resigned that position, I believe, about the first part of June. So I appreciate you allowing me to come today to share with you this information on this survey. And just so you know, this morning I did provide this same information to your stroke subcommittee. So for those of you in the audience, I want to assure you that one of the things that came up this morning is, so okay, you passed this out to the subcommittee, but what about us? It's our information. And we just want you to know that yes, the report goes first to the subcommittee, and at the subcommittee's guidance then obviously would be distributed however you so choose. And we did decide this morning, or the stroke committee decided this morning, that I will provide them with an electronic copy to the chair of the stroke subcommittee, which I can certainly do the same here, and then you guys can decide how you would like to distribute that. So just wanted to kind of preface my remarks with that information this afternoon. So let me share with you then what you have in front of you. As you were informed when we first started out this afternoon, this is a survey that assesses the implementation of the GETAC recommendations on cardiac and stroke system development in the RACs. It is a summary report, and hence the very long title of this report, which says Summary of Survey Responses for an Assessment of RAC Implementation of GETAC Recommendations, which we have labeled a reference document. Certainly, grab one. And what we believe is that what the information in here is some very good baseline information. but do want to stress that obviously this is not a statistical findings report. It is a result of information gathered from a survey that was administered by our EMS department, but which was endorsed and originally requested by the Texas Council on CVD and Stroke and the GETAC Stroke and Cardiac Care Committees, and it was administered through SurveyMonkey. So a little bit about the report. 20 of the 22 RACs responded. The kind of information that was collected was information on the RAC committee structure, some purchasing methods, stroke and cardiac system plans, stroke and cardiac treatment guidelines, medical oversight, regional stroke and cardiac transport plans, stroke and cardiac information collection, pre-hospital triage criteria, stroke training for EMS and public education, acute care capability criteria, and availability of 12-lead ECG equipment on advanced life support, for ambulances. Yes. And of course, there's some other detail in here as well. And the way that the report is constructed, as you can see, is that we wanted to give you some really graphic, some graphic pictures and information about the collective frequency of the survey responses. We could have provided a lot of narrative, but frankly, we wanted to give you the facts of what the information showed based on the responses. There were a total of 61 respondents that actually submitted the survey, and that represented 20 of the 22 RACs. And the actual number of respondents for the RACs, you can find that on page 4 and 5 of that report. 14 of the RACs provided comprehensive information. You know, some of the RACs just provided stroke information, some only cardiac information, and there were just a few RACs that provided just some basic introductory information and information on their structure and purchasing. What I'd like to do now is just give you some highlights in terms of responses, and I apologize for not having an overhead for this, but let me just kind of hit some of the highlights here. And again, when I use these percentages, the denominator here is 20, so I just want you to keep that in mind. Because that's how many RACs actually responded. So let me run through some of these response rates. 55% of the RACs had an acute care committee structure. 35% of RACs had separate stroke and cardiac committees. 44% of RACs had a regional cardiac care system plan. 33% of RACs had developed regional cardiac treatment guidelines, and another 33% were in development. 33% of RACs had developed a regional cardiac transport plan as part of their regional cardiac care system plans, and another 27 were in development. 40% of the RACs had protocols or policies that determine where STEMI patients are transported, and about 33% of RACs designated a protocol for pre-hospital identification of STEMI. Most RACs reported that regional criteria for cath lab pre-hospital activation were in development. Obviously, the information has some limitations because, again, not everybody responded to 100% of all of the questions. But it is, I think, a good reference document for both the CVD Council as well as for both subcommittees. That's basically my report. Again, we realized that this report, the information on the report was actually collected in October of 2011. And of course, the survey was initiated as a result of a previous survey and the 2010 recommendations that came out from the GETAC Stroke and Cardiac Care subcommittees, as well as the CVD Council.
Any questions for Kitten?
How come they didn't respond? What was the problem with the non-responders? Do you know, is that just the inability to get to the right person, or?
Well, I'll give you a little bit of feedback from both our staff as well as this morning from the audience. I believe that some of the questions that were asked around procurement, for example, and infrastructure, I think it really depended on who in the RAC answered those questions, because the survey was distributed, once it got to the RAC chairs, it was distributed to executives, to various people in the RACs. So I really believe that some of the lack of response to 100% of the questions was probably based on whether or not the individual filling out that RAC had any real knowledge of that.
But I guess you have major RACs that don't respond, you know, it looks like Austin, San Antonio, is that?
That I'm not sure of. I would say that was a question you would want to ask. But I can't really, we don't have any reasons listed for why they did not respond.
So,
are you looking on pages 4 and 5?
I just saw next to Austin, with no response, so. And I'm wondering if, was there enough, it's hard, you know, the amount of stuff you get through emails
Exactly.
and whatever to try to, what your spam filter, and so I don't know if this committee could help set up a mechanism to get more data that could help you have more confidence in what you're measuring.
Well, I guess the way I would respond to that is, again, this was an informational survey. So I would say using SurveyMonkey typically is a pretty good way to do that. But there's always folks that are going to have issues with whether or not they're getting that, whether it's coming through their systems or not. But it's my understanding that this was not meant to be a statistical findings report. It's more of an assessment of who's actually been able to put into practice the recommendations that were made by the GETAC committee on these stroke and cardiac care system plans. And again, if I remember the background information I have is that I believe the survey questions were the product of some group development, the Cardiac Council, the subcommittee participants, and our EMS department, as well as our Health Promotion Chronic Disease section. I believe all of those entities were involved in developing the questions. Doesn't mean there's not room for improvement, for sure.
just out of curiosity, do you have a list of the people on the cardiac committee?
Do I have that list?
Yeah. No. For the DSHS, there's still a cardiac committee.
Well, there's the CVD Stroke Count and Stroke Council.
Uh-huh.
Dr. Neil Rutledge is the chair for that. So if you're asking, do we have that list? Yes, sir, we do.
Mm-hmm. In an effort to perhaps streamline and certainly better organize the STEMI activities in Texas, is there a possibility that some representative from that committee could be advisory to this committee? Is that a possibility? Is Jane around? Pardon?
I can take the question.
Would you? Okay. I think that would be, pardon?
She's outside the door. Let's see if we can get her in. I can ask her right now.
Okay, that'd be great.
I hear she's right outside the door.
Could we clarify?
Why don't you ask the question?
Can we clarify what committee you're talking about? I'm not familiar with the existence of the DSHS.
If you don't mind, I can address that. Joel Roma with the American Heart Association. The Cardiovascular Disease and Stroke Council was created by statute in 2005. They're good. Way on. Can you hear me? How about now? Okay. That council was created by statute in 2005. The Heart Association was one of the drivers behind it, working with DSHS. They're gubernatorial appointees, as mentioned. I'm not sure if Dr. Rutledge is a chair, but Dr. Tom Tinner was a past chair.
That's correct. It is Dr. Tinner who's the chair.
That council has the authority to lobby, unlike yourselves. They've just developed their legislative agenda. One of their number one issue is surveillance, collecting data for stroke and data and STEMI issues. Dr. Wozniak came and presented to the CVD Council about a year ago. And we've been trying to encourage both entities to work together as well to advance whatever recommendations you may have. They can actually adopt their agenda and go and lobby for it. It would be wise probably to have more interaction with them. They meet quarterly. They are, the makeup varies from neurologists, family physicians, nurses, caregivers, and then different respective agencies, DARS, DISHES, DADS, Texas Education Agency. Their next meeting will be on a Friday, November 4th, perhaps, I believe. And they do submit a report to the legislature, and they are given their by statute are to write a report and recommendations to help impact heart disease and stroke in Texas. So somehow you guys could probably work together. That'd be awesome. We look forward to that.
And just to supplement that, Dr. Neil Rutledge, who, as I understand it, is the chair of the stroke subcommittee for GETAC, he is on that council. And one of the things I might also share is that there was discussion this morning about redoing this survey again, since this is more or less a baseline, picking a time frame to do the survey again. And of course there was also discussion about the questions and that those need to be reviewed and so forth. So I think there's an opportunity here for anybody on this committee to be involved in that, if in fact that's the way that the subcommittees and the council would like to go.
Yes.
Your question was not answered yet, and your question was, could somebody from the CVD and Stroke Council sit on this committee? Was that your question?
Well, either sit or participate on the committee.
Well, to sit on the committee, they would have to...
I understand they have to go, but could there, I mean, is there a mechanism for an ex officio member of the committee on a regular basis, perhaps? So that down the road, perhaps there could be some more collaboration, more intense collaboration. It would seem to be reasonable.
I can certainly take that request to Dr. Tenner, who's the chair of that council. I'd be glad to do that.
Yeah, I think I have his contact information.
Okay.
So I'll try to ping him and chat about this and see.
Okay.
So, I mean, we were on the Heart Association board together for a long time, so I think that's would be something to pursue. So.
Hey, Richard,
Yeah.
may I suggest a prisoner swap? I'll be there.
Are you volunteer?
I'll be there November 4th.
Uh-huh.
So I'll be our representative to there, and so you can come up with a name for. How's that sound?
That's fine, certainly. If you would, so will you be in contact with Dr. Tenner about that, or is that already on the agenda for that meeting?
Yeah. Are you invited to the November 4th meeting?
No, I'll try to get myself invited, I guess.
I can take that request back if you'd like. I just need a little bit of information, or if you would feel it would be more appropriate for you to contact Dr. Tenner yourself, that's fine too.
After our meeting, I'll come meet with you and we can exchange contact information, and you could put me in direct contact. I'd appreciate it.
I'll be glad to do that. I'll be glad to do that. I'll leave you my business card and I'll be glad to do that.
There is on the DISH's website, the same site page that you're on, the CVD Council is probably one click away. It has a roster of the rules. They're public meetings, they have public comment, but Dr. Tenner's great about putting folks on the agenda at a request. So, and that they just filled I think all their spots on that council as well. So it'd be a good time to start the discussions.
Todd, you have a comment?
Well, I was just going to ask or recommend that if this survey is going to be repeated, in looking through the number of respondents from the different RACs, it's true we had some RACs that didn't respond at all, but some we have one that responded, some up to 6. So I don't really know who it went to in the RACs, but if we're really going to truly survey the RACs to make sure that the answers are consistent, I think that the survey should go to the executive directors of the RACs, and that they would be the ones that would be best suited, because if this is going to different individuals at different facilities and different services, and if they don't participate in the RAC on a regular basis, they might not have known some of the answers, so I'm not sure if we have
My comment was going to be as a follow-up to Dr. Wozniak's. Do we have a mechanism to communicate, maybe more importantly, to the acute care committees? You know, a direct line. I mean, I would think that would actually be the person. I would think some executive directors who may be more involved in other aspects, trauma, stroke, may or may not be as in tune to cardiac care in the bigger racks. So should we have a master list of cardiac care committee chairmen? Granted, everybody doesn't have a cardiac care committee, but for those that do, that might be the best. And then I'm also thinking in future when we're trying to, you know, send out information, it would be nice to know that it's going directly to the cardiac care committees, in addition to the executive directors.
And let me speak to both of those because actually that's one of the limitations that we found with the information we got. First of all, the survey was originally sent out by the Office of EMS at DSHS, and that was because they have the contact information for RACs and so forth. So they sent the survey out, but it was sent to all 22 RACs, including the executive directors and the chairs. So that's who it was initially sent to. Now, who they may have passed it on to, that was at their discretion. So again, not only is there not a very clear picture in terms of who actually completed it and sent it back, but what we did find is that with some of the responses, multiple people in the same rack filled it out, and sometimes there was some conflicting information. And you'll see that in your report. Yeah. So to address what you're saying, I think, again, if this is done again, certainly we've learned some things from this first survey and the things that we would want to be more clear about in terms of our questioning or identification. Those are things that certainly we can include, you know, you would want to include in the next survey.
I think Lonnie may have some overlay information from the action data for the various racks. Is that a fair statement?
Not until we start getting those regional reports back. So right now we have state data quarterly, but until we start getting the first aggregate regional reports are going to be available here in the next couple of weeks. And for those who are signing on, probably we'll see in Texas the first ones in about a quarter.
Oh, so you have to have a hook.
Well, no, actually anyone can do it, but it's new. So we don't none of our regions have it yet. The ones that are participating in the Accelerator project will have that information for their region. Austin is close to getting, you know, the consent form signed. All the hospitals have to sign a consent in the region for their data to be compiled.
We have a speaker.
I'm Leanne Bedrick. I'm the EHS program manager for the North Central Texas RAC, and since it doesn't seem like any of you guys actually filled it out, I was just going to tell you from our perspective, we got it. It came to the chair and the executive director. Executive director sent it to me. It asked us specifically, the instructions in it were to answer the first part and then forward it to your cardiac and your stroke committee chair. We were told to do that, so that's what we did. We had their contact information in there. It should be in there, and they're the ones who filled out their sections. So you should have gotten multiple responses from each RAC because that's the way we were told to do it. So if you want to do it another way, it just needs to be in the instructions, but the instructions were to do that, so that's why.
I mean, I think you need to direct that to them, right? Yeah,
well, actually,
no, yeah, no, I understand.
Y'all were asking questions.
Sure.
Some were one, some were two, so that's why, because that's how it was.
Well, I think that's my concern with, if that's the way it was worded, and yet some of them, even our RAC, there were 6 respondents. Well, there's not 6 chairs to the cardiac and stroke subcommittees, and there's only 1 executive director and 1 chair. So at the most you should have had was 4 responses. Some only had 1, some had 2, so there was no consistency. So I think if it goes to 1 person, if they don't know the answer, then they can get with those committee chairs and get that answered before they finish filling out the survey. But if it keeps getting forwarded on, there's no telling what kind of information we've received.
It sort of raises an interesting question, and that is, what is the link between the various committees of GETAC and the RACs, if any? Is there any? The question was, what is the linkage between the various committees or subcommittees of GETAC and the RACs, if there is any connection? It would seem to me that the lines of communication could probably be improved somewhat. So this cardiac care committee, does this cardiac care committee have access to the RACs? Directly or indirectly, and what, if it's indirect, what's the mechanism?
I beg your pardon? Could you say that again?
DSHS would be the mechanism as a link.
To the GETAC subcommittees? Well,
No, to the RACs. From our committee to the RACs.
Well, it needs to go through the council itself.
So could somebody supply us with a map of the communication line? I mean, if there are all these rules, it would be nice to know what the rules were, and then we could pursue it. No?
It is. If the committee has a request of the RACs, it needs to go through the council, the GETAC council.
Yeah.
The GETAC council.
That's right.
Okay.
That's kind of how we got to this survey.
It is.
Dr. Pillar requested for the survey to take place. I was at that meeting where Pillar asked us to do the survey, and it came about through discussion in that meeting to have GETAC request the RACs to respond to Dr. Pillar's questions. That was the origin of this whole survey.
So I have one thing, a comment that's going to demonstrate my ignorance, but a proposal to follow up. The comment is that, is there a possibility to increase the likelihood that you get good information? I know once a year, this is the ignorance part, that there's a major meeting for the EMS, and I think all the RAC directors are there. Why not just make that your spot where you have a concentration of people in one room, make that like a to-do item? They could certainly assign it to their best person who gives that information. Again, this is ignorance. So the proposal I have from this committee is that I find this to be very valuable information for us to get. You know, if it's one of those things, again, if you don't measure it, you don't know where to direct your attention. I think you got a great survey here, and I got some nice questions. And so we're just worried about the confidence of the data. And so I think maybe you said this is a good initial effort, and I agree with you completely. And so maybe this committee make a formal recommendation that we think this is good stuff, let's try it again, and let's get a little more organized in assuring the collection of valuable and thorough responses.
I think in terms of the confidence of the data is simply the summary of what was responded to. So the data is accurate in terms of what's been presented to you. The real question is, what do you do with it? Because it is pretty basically a reference document at this point. It doesn't give you scientific findings in the sense of being able to tell you necessarily. It doesn't tell you where to direct your attention. You have to, it's simply a summary data. That's all it is. It's frequency summary data. That said, I would agree with you that if both subcommittees and the council want something that provides them with a little more statistical, some statistical findings and analysis about where you can direct your attention, then that's a different study, basically. That's a study as opposed to a survey, really. And I would suggest that, again, I think you're on the right track in terms of the council, the two subcommittees. There needs to be, I would say, some collaboration that says, what do we really want? And then we can assist in helping design that for you. But I think in terms of what you want, obviously that collaboration would need to occur between the subcommittees and the council, and then we can propose from there, along with our partners, our EMS partners, what kind of survey, study, or whatever that would get you what you wanted.
Okay, thank you very much. This has been very interesting, and hopefully we can pursue it fruitfully.
And just one more reminder, as I said, the stroke subcommittee is thinking that they want to do this again, whatever this really is. And so I would just encourage that we can all get on the same page, and I'll be glad to facilitate that with the council, with the Texas CBD Council.
So are you volunteering to make a report at the next meeting?
No, sir, I'm not.
Okay.
Very respectfully, I decline.
Just
It
curious.
doesn't mean that I might not have to.
Okay.
But,
All right. That's fine.
what I would hope is by that time, as we are very much on our way, there will be other folks here that will do that for you.
Great.
But if I'm still here, then if I'm asked to do it, I'm a pretty good soldier. I'll be glad to do it.
Thank you so much for
I
coming.
have one last question for Kitten.
Yes, sure.
So may I share this information that came from my rack with my rack?
However, this committee decides to, whatever this committee decides to do with this information is totally up to them. I would like to go ahead and provide an electronic copy to the chair as well, because we're going to do that with the stroke subcommittee. And I certainly want to be fair about at least where we've distributed it, but it's really up to the subcommittees about how they decide to share it after that. If at some point the subcommittees and the council want to see it posted somewhere, then we just need to have a discussion about what's the best place to post it. Does that answer your question?
Yeah.
Based on this morning's meeting with the stroke committee, there were racks that didn't know about this and would like a copy of this, and I think you suggested that the committee release it to the racks.
Yes,
And
if that's what, yes.
If that's the case, then as a rack director, I would like to encourage your committee to release it to the racks, since it's a survey from the racks.
So we need a motion?
Okay, yeah. Lonnie's going to do it.
Yeah, I'll make a motion. Would we do that? Who would best distribute that? Would you best? I mean, to the RAC executive directors or RAC.
We don't have them there.
Who is the
results of the survey we do not have.
Right, but the electronic results. How best to get them to Daryl and the rest of the group so that everyone gets them.
The EMS has that's who sent it out initially.
Correct.
Right.
We have a current list
Right.
of the chair and executive director email addresses.
Correct. Right. I would just encourage however y'all
So the
decide to
motion,
do that.
Lonnie?
Yeah, a motion.
Yeah,
To send the electronic results through Department of State Health Services to all of the RAC directors.
So if I understood you correctly, you suggest that we share the results with the committee members and the cardiac care committee members and the RACs.
Yes, thank you.
Is that correct?
I would add rack directors and chairs.
So RAC directors.
So that the acute care committee in the rack actually gets to see the data.
All right, so can you write that down so I can put it in the minutes?
Sure.
Mr. Chair, if I may, just for consistency's sake, I'm not sure how the stroke subcommittee is going to distribute the information, so you may want to at least let them know that RACs are going to get it through you guys.
Okay.
So Emily, we can send it to you to distribute.
You say we can send it to you, who do you mean?
Well, like if Dr. Smalling
I'll
wants to
send-
send it out.
Okay.
Thank you.
So anybody opposed? Passes. Thank you.
Thank y'all very much.
Thank you. Moving along, I see a slide set up there. So Catherine, you want to talk about your report?
Sure. At the last RAC meeting, you asked for some STEMI case reports and successful STEMI treatment systems. And so I got with Dr. Purse out of HFD, and he gave me the makings of a great STEMI snapshot. The basis for this, as we all know, is just to give EMS a feedback on how those STEMI patients were treated. And the makings of a great STEMI snapshot as far as he's seen, and he's seen quite a lot from a lot of different systems, small, large, and he liked some of these. Multiple ECGs, including the EMS ECG, which showed progression For EMS as a teaching tool, that can help them to see that sometimes nitro, aspirin, all that can make the it look a little bit better, but upon admission to the ER, it can still be something that goes to the cath lab. Before and after angiography pictures, he also liked the lesions illustrated angiographically. Times and calculated intervals, that was real important. Door to ECG time, from patient contact to ER arrival, and of course your total ischemic time. Comprehensive focused narrative about what happened. It's always good for EMS, they understand their part of the picture, but they don't always understand if they don't make the door to balloon of 90 minutes that there was the patient coded in the ER after they leave, or there's other incidences that happen within the hospital. So if they don't make that door to balloon time or anything that might have happened in the cath lab, sometimes EMS doesn't have that full picture. So it's great for us to include a narrative. The other thing he likes is that no patient identifiers on any of the STEMI snapshots. And his thing is if he leaves it on his desk, there's no HIPAA violation if somebody comes in and sees it. Any questions on this? I'm going to show you a couple of examples. These are some examples we have from the, some systems in Houston. This is one that he likes quite a bit. It, of course, as you can see up here, where's that pointer? Is that it? I don't know where the pointer is. As you can see on the top left, it's got the EMS EKG that was transmitted to the physician. He also includes the drawing that the cardiologist does that he puts in with the cath report. And then, of course, on the right side, you can see the pre and the post pictures. And then down in the left bottom corner, that's the narrative. Also in the middle, there's all of your time intervals.
Except for symptom onset.
Except for, I don't know if he has symptom onset on there or not.
So, Kath,
symptom onset is not on that one?
No.
It's on another one.
Catherine, so this was this is a STEMI feedback tool that a STEMI coordinator at a PCI hospital uses, compiles all the information, and sends it back to Dr.
EMS.
Purse.
Mm-hmm. So this is closing that information loop.
To the EMS, the service that delivered the patient. But it also goes to the STEMI committee members of the hospital, so everybody can see how they're doing and encourages communication.
Absolutely.
Go ahead.
Good point. This is another one. As you can see, same elements. We've got an EMS EKG. We've also got the time elements, information about risk factors on the patient, what the outcome was, and the pre and the post shots. And just another one. It's just to show you that there's different ways that you can skin a cat, however you want to put the information on there, as long as those basic makings of a STEMI snapshot as far as the most important thing, like you said, he wanted that EKG, and he wants pre and post shots and a little bit of information about what happened with the patient. However you want to put that together is fine as long as those elements were in there. Any questions on STEMI snapshots or on case reports?
Well, so the original idea was to have sort of a workbook available on the website under our cardiac care committee section that people could access to look at tools for STEMI systems and so forth. Would this be helpful around the table? Yes?
Definitely.
And then we probably ought to be doing updates and so forth. None of these had onset of symptoms, by the way.
I thought one of them did.
No.
I'm sorry, Dr.
It's I mean, it's okay. I mean, it was just, these are things to talk about and say, look, let's put onset of symptoms on there. I know for a fact that one doesn't. So, now we have had some questions about how to get this information on the DSHS website. How are we supposed to get this information? We have a bunch of stuff I've got on a thumb drive to load on the website.
Well, Jane asked me to mention that at GETAC, council meeting tomorrow, they'll be discussing a process on approval of such things as postings.
I did that last time. I presented it the last time. Everybody went, So we need a real motion this time. Is that correct? Okay, I'm learning. Okay.
And then did you want to go over STEMI treatment systems?
Any questions about this? Anybody in the audience find this helpful, not helpful? Yes, everybody says helpful. So I think it's really helpful. And it's interesting, it really came out of one particular hospital, and then once the EMS group got a report from that hospital, the other hospitals said, well, we can do better, and then they did it, and so now there's sort of a race to see who can do the most accurate, best, blah, blah, blah. So this is, I think, very helpful. Okay. Your next item then?
You asked about different STEMI treatment systems. This is something else you wanted to post on the website. Two of the different ones we found in the SETRAC area, ER physician-activated cath labs and then paramedic-activated cath labs. I'm going to give you just some highlights. Again, Dr. Peirce gave me some feedback. HFD has a difficult task. They deliver patients to a lot of different facilities. Specifically, we've got 33 PCI facilities in the SETRAC area, and he delivers to 30 of them. So he has to figure out how he can pre-activate 30 different cath labs that are 30, interventional groups, all these hospitals, ER systems. And so these were the points that he felt made his ED physician-activated cath labs most successful. All of his units, all of his ALS units have 12-lead acquisition and are able to transmit to those ERs. If the ERs do not have transmission capability, then he can fax them. Transmission to the 12-lead takes about 15 seconds, and usually it goes directly to where the emergency physician is, who can then activate STEMI. They transport STEMI patients to 30 facilities that are recognized as STEMI receiving centers, and 29 of those allow a pre-activation based on the transmitted 12-lead EKG. So he feels that those are what was successful for, what's worked for him in Houston. Any questions on that? And then the other system that we have is paramedic activated. This is a little more complicated. Houston Northwest partnered with local EMS agencies to activate STEMI off of paramedic activated off of paramedic ECG interpretation. They work with 3 different agencies, HFD, Harris County, and with Houston, Cypress Creek. They're authorized to activate off of the paramedic interpreted ECG. They rotate paramedics through their cath lab and through their emergency room. They spend about 8 hours, and a couple different of their clinical rotations are actually spent within the ER and the cath lab. The reason why they feel that that's pretty successful is because the cardiologists are able to actually develop a relationship with the paramedics. They're actually able to quiz them, present them with EKGs, talk to them about STEMI imposters. Building that relationship makes the cardiologist a little more comfortable with allowing them to get out of bed at 3 o'clock in the morning. Paramedics receive the advanced ECG 12-lead training from their EMS agency, but they're also able to receive that training at the local hospital. Any false activation, paramedics are required to repeat that 12-lead ECG training within the quarter that they had the false activation. EMS agencies are invited to attend the STEMI meetings because they can get that feedback. And of course, the reports are shared with all the EMS agencies so the crews can see the results of what they've done. Any questions on that?
Well, so there were some other thank you, that was very nice. There were some other members of the committee, right? So Christine, you were on that same assignment group.
That's kind of what Lonnie and I had a long discussion about, bringing in people from the RAC to actually present their systems. So that's kind of what we thought we might focus on, unless you would like something different.
Well, so no, I think a parallel approach would be good. I mean, if for instance, is Dudley still here?
Is he hiding?
So Dudley's had some success in San Antonio, and he likes to share his success. And so having Dudley's story on the web so people could see how they did it in San Antonio, and perhaps your story in Corpus and so forth, we thought that would be useful so people could say, gosh, we're having trouble. How do they do it in El Paso or whatever? Is that doable or not doable?
I think that's kind of what Lonnie and I are intending to do, is to set up so that each meeting somebody presents. So this time we had a presentation from the Houston area. In each meeting, somebody presents their own, rather than me talking about somebody else's program.
Well, no, I'm not. No, I'm just saying if you guys could reach out to various areas and get something written and with some graphics and put on the website in addition to having a presentation, interactive presentation.
Yeah.
Does that make sense?
I think it'd be helpful to have both.
Yeah, that's what I'm saying. That's what I'm saying.
We do have the Austin Regional Field Guide that has all of the regional STEMI protocols and survey results and data collection tool and those kinds of things, all compiled in one written document that I have in my file to be loaded. But I think it'd be great to have one of the volunteers from the system speak about it as well.
And it probably would be reasonable to, have a sort of a working group to sort of work through it and have sort of more or less a uniform format and get the information out in something that's sort of comparable, like population size, percent EMS, percent helicopter, percent walk-in, stuff like that. Dudley, you want to mention in a few minutes about what's going on in San Antonio right now? And would somebody from your RAC be willing to give sort of a playbook for how it worked in San Antonio?
Sure. We did that a while back. We'll be happy to do that again. And next time y'all meet may be a good time because we're going to have our accelerator project well underway and have had our kickoff meeting, which is a week from today. You think I should know that? We're kind of excited about the accelerator piece because our RAC is so huge and we have so many outlying areas. It's about 3 hours or more by car from San Antonio out to the far western edge of our RAC. So the ability to start coordinating the care that's provided out there is something we're pretty excited about. Our statistics, and Dr. Wampler's here too. I'm not going to let him get away with this, but he's put together, him and his staff and Dr. Manifold's, he's with Dr. Manifold at the Health Science Center. They do our data work. Remember, we have that really high-tech registry called Excel. And they've done a lot of work showing how our system has progressed since before we started until now. And I believe we're at 93% of our STEMIs get care in under 90 minutes, get their artery open in under 90 minutes now. So we're pretty happy with those numbers. Now, granted, those are folks that are coming in from Bexar County and the first ring of counties around Bexar County. So if they can make it into town in a reasonable amount of time, 40 to 45 minutes, either by air or ground, they're coming into San Antonio. Well, we don't know what is happening in the other 15 counties in our region. So that's where we're looking forward to the accelerator piece. We've done a lot of the same things. We have 17 PCI centers in San Antonio. They've all signed a letter of attestation that outlines the exact same thing that Dr. Purse outlined there, that the ED physician can activate. They have a system for one call activates the lab. They have internal procedures to shorten their door to balloon time. They share their data with us. And then we did a letter of attestation for EMS agencies that plan on activating the cath lab as well. Because the PCI center said, that's cool, we're agreeing to some stuff, but what's the EMS agencies agreeing to? So that involves the 12-lead training, 12-lead capability, participating in PI process again, and sharing data from the EMS agency as well. So we've got that on both sides of the system, and it's going pretty well. It'll be interesting to see what happens now that we start reaching out into the region.
Great, thank you very much. So I guess we have at least 4 or 5 that could be assembled, and then you guys could pick out who you want to speak and so forth, and that would be, I think that would be terrific.
You're looking for one per quarterly meeting?
That's what you guys suggest, is fine with me, but I think we ought to assemble more than one, per quarter with access to it. So if we could have 8 maybe STEMI systems in the various regions, that would be something to shoot for.
That would provide the written
documentation, how to do it in a community on the Gulf that's a certain population, for instance. Okay. We also were tasked with putting together literature. Todd submitted abstracts, and I've got those, and I can give to DSHS. I also have about 50 STEMI articles that I think are reasonable, PDFs of those, and there was some discussion about putting those on the websites versus links to them. I think the link process would be challenging, but somebody probably knows copyright laws so that we can say, yeah, I think we have to look into the copyright issues, but if individuals if they're do not copy and you can access them for informational purposes and it's an academic or public health environment, I think there's probably some clauses that allow you to do that. So somebody needs to pursue that, perhaps at the Department of Public Health. So I don't know that I've missed anything. If I missed anything about things that we were going to do, anybody remember? While we're thinking about that, do we have any public comment? We have 21 minutes and 47 seconds left.
I guess before going back to the survey, I mean, we haven't really had time to digest it and read the survey. But I guess one question is, what are we going to do with the survey? I mean, we have this information, and we're going to all go home and read it. Do we want to specifically try to come up with what we think are identified deficiencies, identified issues that we further encourage the RACs to address and work on? Otherwise, I'm not sure.
I hear Dr. Mixon making a motion that he and Dr. Wozniak collaborate on this to look in more detail at the survey and suggest opportunities.
That's exactly what I said.
That's what I thought you said. So that was a motion made. I'll second it. Okay.
And also, I think if we have, if it sounds like if there's another survey that's conducted, that if we kind of have our questions that we're interested in having answered in the queue so that we can start looking at those. Okay. I know we started that list already, so we can.
If you guys could formulate this, I will, you could transmit it directly on the 4th, but what is it, September? November the 4th. No. Is it November the 4th? That's what they say. The state? Okay. I'll also call Tom Tenner and suggest that we will be happy to supply some suggestions for the next survey. Is that okay? Okay. All right. No public comment? No. Catherine, you want to tell?
On the table outside, I put these brochures. It's talking about the Houston STEMI Conference. It's coming up September the 22nd. It's going to be held at Rice University. All the information is listed on the back. You can go through setrac.org, or the direct conference website is stemiconference.org. We are going to have CEs there for physicians, for nurses, for paramedics, and for rad techs. So it's everybody that is involved with STEMI care. Any questions?
The other very nice thing for those of you in the group who are STEMI coordinators, if you bought your Cycle 4 manual already for Society of Chest Pain Centers and you get that free workshop and you have to fly to Ohio to go to that workshop, they're actually, they never bring it outside of Ohio. They're bringing it to Houston, and they're doing it the 2 days prior to the STEMI conference. So just you can make it a road trip. It makes it a lot more affordable for hospitals. They're bringing it to us.
So Karen, you have anything to share with us?
It's, you mean as far as success?
Yeah, success
general life.
What you did for your summer vacation? Or?
Yeah, I haven't had that yet. You know, when we look at our RAC is so populated that what we're doing in Dallas County related to the Caruth grant is winding down. And so what we're really trying to address now is the sustainability. And in that, we want to, when we talk about sustainability, and some of the educational things that we want to do, we also want to spread to the rest of the RAC. So, so we're working with the RAC right now. It's moving forward quickly, I think, to include as many people as we can, because we have had just overwhelming success in Dallas County. We have paramedics that are activating the cath lab from the field. We've had very few false activations. It's just been very successful. So, so we want to recreate that model everywhere we can.
So I'm hearing a new chapter in your section. So you guys are talking about creating STEMI systems, and Karen could probably add how to sustain them. How about that? Maybe Dudley could provide some information too. How about that? Would that work?
Yeah.
Yeah. Good. And, Josie, you've been writing things. Do you have anything to share with us?
No, I'm just taking it all in, making notes, and making sure that our RAC is doing that.
All right. So where's your RAC? Tell us about your RAC.
We're one of the ones that have our stroke, I guess, regional plan. We call it we call it like a guidelines, what we're calling it. We have 22 RACs in our region. There's some that are still not wanting it to be a regional guideline. They have physicians that want to keep it under their thumb. We're trying to talk to those medical directors. We've put our stroke one in place, and we're working on our STEMI. We're really close on getting that out as well. We're one of the ones that are in progress.
Where is your RAC located?
We are in Abilene. We're, like I said, made up of 22, and we're from Frontier Rural EMS to Critical Access Hospitals, and ours is a level 4. We bring in anything from CVAs to STEMIs, and we have an hour going to Abilene to a PCI facility, or we have an hour and a half going to another one that's in Lubbock. So we're actually, our hospital's in a cotton field, basically. And
Wow. So would you be willing to help these young ladies with their committee? Because you could provide, I think, a valued change of venue for them.
Yeah, that would be great. I've been to Abilene, I've been to their RACs, and I've been to all their referring facilities and all their receiving centers. And they are really, in the past probably 18 months, really been working hard at pulling it together. Really, really hard. And like she said, they've run into some political difficulties, which I'm sure you could share.
Well, there you go. See, there's another chapter, and it's solving political difficulties. That would be a good tips and tricks. Do you have any tips and tricks for solving political difficulties?
I think that the best, what always works best is convening, if a neutral body convenes the group. So the RAC is perfect for that, seen as a neutral body. I actually have a PowerPoint presentation related to that I can send to you, Josie, but I would say that's the #1 way to diffuse the competition is if everyone is coming together and under for the same goal. Creating a mission statement so everybody knows exactly why they're convening is also helpful.
So at our hospital system, they have a slogan, breakthroughs every day. So I think we just had a breakthrough here. So I think we might adopt that for the committee, breakthroughs every day. I think there's a lot of energy and obviously a lot of good information. And now we have to figure out how to get it on the web and share it. Speaking of that, Robert, are you awake?
I'll just give you, if for some reason anyone that's here has the urge to watch our meeting over, make sure what you said or you volunteered for, you actually volunteered for that. It's at GETAC. They're very kind to facilitate this. I think a couple of years ago we talked about the ability of people that couldn't get to to Austin for this meeting. So please spread the word that it looks like you go to ttaf.org, and the bottom right of the page, I guess you can find this video. That's what I was told here. So you can spread the news to those who didn't have the opportunity to be here.
Isn't there a link to that on the GETAC website, on our committee? To the TTAF video?
I don't think so.
Isn't there? The last time I looked, there appeared to be. I didn't try it, but there was a.
I think we decided not to do that, so that if anything changed, you just go to TTAF, but I could be wrong.
That would be helpful. Yeah, that would be helpful, I think. So, I mean, if you want to, I mean, for people to pay their own parking and their own hotel and their own meals and stuff, to come to these meetings and do the work, it would be nice for the work to be shared with the population of Texas like you're supposedly it's supposed to. So that would be helpful. Okay, go around the table? Anybody have any other comments? Next steps? I think we have our work cut out for us. Okay. We have 11 minutes and 48 seconds left. No more public comment? I think it's Miller time. Thank you very much. We're adjourned. Thank you.